Hello everybody and welcome. My name's Sheila Samuels and I'm one of the non-executive directors here at Liverpool University Hospitals, or LUFT as we are commonly known as. So thank you for joining our public members virtual event today, which is on dementia, and it'll be presented by Lisa Roberts, who's our Head of Operations for Medicine, Older People and Stroke, and Aideen Cronin, who's our Delirium and Dementia Lead. So before handing you over to Lisa and Aideen, perhaps I can just tell you a little bit about my role as non-executive director here at the Trust. So I'm a member of the Trust Board of Directors, and the Trust Board consists of executive directors, and they're the people who are employed full-time to deal with the day-to-day running and operational aspects of the Trust. And as a non-executive director, we're really engaged part-time. But as with executive directors, we're still all responsible for the running and the strategic direction of the Trust. It's just that the non-executive directors, we come to the Trust for different reasons really. And that reason is because of our own backgrounds. We tend to have either worked in public sector or other major organisations in either governance, finance, human resources or other specialties, clinical as well. And we devise strategy with the executive directors, and also we are there to ensure that strategy is delivered. And at the Trust Board, we ask questions. So we ask those difficult questions. You know, what are we doing? How are we treating our patients? How are we treating our staff? So we're there sort of as a critical, supportive friend to the executive directors, but also still responsible for what happens within the Trust. As for myself, I've been a non-executive director now, this is for about 2 years. Before that, I was a non-executive director over at the Walton Centre, and this is my first term of office here at LUFT. And my specialty background is human resources and governance, so hopefully I can bring that particular dimension to things here. As well as being as a member of the board, we sometimes have special roles that we perform, and mine is as well being guardian within the Trust. So I support the Trust Board and members of staff in making sure that we look after staff and ask those questions: how are staff coping, how are things? I'm also what they call a senior independent director, which means that I'm responsible for appraising the chair on behalf of the Council of Governors. So as non-execs, we're appointed by the Council of Governors, and we report to the governors at their meetings on how we are holding executive directors to account and our performance as non-executives on the board. It's a great time to be with LUFT and a really exciting role. So without further ado, I'll now hand you over to Lisa and Aideen to take you through our presentation on dementia from a carer's perspective. Thank you.
So thanks for that, Sheila. So as Sheila said, I'm Aideen Cronin. I am one of the consultant geriatricians here based at the Trust, and I'm also the Trust Lead for Delirium and Dementia. Alongside my colleague Lisa Roberts, we're going to present a dementia occurrer's perspective. So the aim of the session today is going to be just a brief kind of discussion highlighting the number of carers and the impact of being a carer, and then the main body of the talk is really talking about a carer's perspective involved in supporting someone living with dementia on their journey, with some final slides at the end for signposting to support. And I just want to mention that this is the second of 2 talks. So there was a talk earlier in the year that was in April, and that looked at dementia, and that was more of a clinical overview, talking about diagnosis, treatment, and some of the medical issues that that can impact on patients living with dementia. This is a kind of an enhancement of that and looking at the other side. Now, I've been quite lucky. I've qualified in 2008, and pretty early on in my training, I knew I wanted to work with older people. I considered myself to be quite confident and comfortable in managing older people and the complexities of their medical issues. But I must say, this is my granddad Tommy on this picture here, and he himself was diagnosed with dementia. And I must say, observing the the challenges that came from my dad and my uncles in terms of those changing relationships and roles, the navigation of the care system and accessing support, and just the practicalities of care, and also those feelings of guilt, and witnessing it firsthand really was very eye-opening. And kind of as a consequence of that, I think we really need to be talking more about carers and carers' perspectives. It can be a very difficult journey to be on, and we're talking about dementia. We know that this is a big health problem. This is over 900,000 people in the UK have a diagnosis of dementia at the moment, with those numbers set to rise. When you're talking about patients living with dementia, you have to talk about the impact on carers. There's a massive workforce of informal carers that are supporting our patients in the communities, keeping them functioning independently, keeping them safe. And it's a bit of a crisis really in terms of what's on the horizon. And when we're talking about carers, we've got to talk about the impact on the change of relationships, that carers can feel socially isolated. It can negatively impact psychological and physical health, and lots of surveys and reports have identified that those who are in a caring role have higher levels of chronic health problems and disability, and also higher levels of mental health issues in comparison to non-carers. And then there's also things like the financial cost of being a carer, and that's not just the fact that perhaps you're not able to work the hours that you'd like to work because of your caring role, but it's also those other details like, you know, the higher energy bills if you're having to deal with washing, it's you know, adaptations, it's increasing transportation needs, all of those kind of things which is, you know, is a massive part of being a carer, impact on carers. Just want to talk briefly just about the carers assessment, just to highlight that really, just whilst we're talking about carers, and that's a legal right. It's for anybody in a caring role, but definitely would encourage those that are caring for someone with dementia. And it's an assessment that can be carried out by the local authority, which just highlights some, may identify some support that you're able to access, which may make things a bit easier, and you can access it via your GP or a self-referral through adult social services. So I just wanted to use that this as an opportunity just to highlight that as a platform. And I'm now going to swap the seat with Lisa, who's going to talk about her family's journey alongside her dad's as dementia.
Hi everyone, my name's Lisa Roberts, and I'm, as advised before, Head of Operations for Older People and Stroke here at Aintree. And today I just want to talk you through the story of my dad, Danny Smith. So I'm going to take you through the journey from diagnosis and how that was delivered and how that felt to us as a family, and talk you through home life and how that impacted, specifically for mum, but for all of us living with dad with dementia. I'm going to talk you through life in the nursing home and his admission to the nursing home and how that was for us as a family. I'll talk through when a decision was made to not actively resuscitate dad, and I'm going to talk through how we put an end of life plan in place for dad, and briefly just about dad's death. And I particularly want to do this presentation just so that I can share my story with people out there when they're going through such a difficult journey. So this was my dad, and as you can see, he was a big 6'4" guy. He was always head of our family. He made all the decisions, and he had a number of medical problems, but he was admitted to hospital this particular time, with what we thought was a urine infection. And I remember going in to speak to the nurse that night and asking for an update on dad, and she told me that he'd had a scan of his head that afternoon and that he'd been diagnosed with vascular dementia. She told me that while I was standing up at the table and she was sitting down, and she didn't really give me any other information, and naively I probably never asked any further information. So on the way home, I told Mum about the diagnosis. And at that point, I suppose we knew that dementia meant cognitive impairment, but we didn't know that there was any stages of dementia. We didn't know what impact it was going to have on our life. We wasn't given any written information or anybody else to speak to. We didn't get any follow-up, so we were sort of left in the dark, really. And so we took Dad home and we settled into home life. So Dad was, his mobility wasn't particularly good, but quickly after the diagnosis, he seemed to be in hospital repeatedly. And every time he was admitted, we thought he'd gone in with a urine infection. And every time he was treated, he started to get better within a couple of days. And we'd want to take him home. The staff would say, well, you can't take him home. He needs an occupational therapist to see him and a physiotherapist to do an assessment. And we tried to say that we'd had these assessments before and that we had everything in place to maintain Dad's safety at home. But despite that, we were asked to have this assessment every time. And I would say that we must have had it at least 30 times, the same assessment with the same conclusion. And I suppose what I'd want to say at that point is we probably came across as a difficult family, asking a lot of questions and maybe a bit agitated at times. But we were just a family trying to deal with a difficult circumstance, and we just wanted to take our dad home to a place of safety, and we considered his home was more safe than being in hospital. Sort of fairly soon, Dad started with urinary incontinence initially, and the impact on that was big for Mum at home. So it meant that she was often having to change his clothes several times a day. It meant that she was having to, change the bedding. And being of the older generation, she wanted everything perfect. So every time she washed the sheets, she obviously wanted to iron them and put them back on the bed. And when patients are in hospital, it's a lot easier to deal with that because you just put things in a linen skip and get clean laundry. But obviously Mum couldn't do that, and it was exhausting for her. Dad had always been able to cook, and but quickly he'd forget he'd left the oven on. He'd only know when he'd smell the burning, and Mum was then frightened to go out of the house, so she couldn't really even go out for a coffee with friends, and she was restricted to the house, which was really difficult for her because she'd always been very active and going out with friends as such. He quickly forgot how to use the television. He could no longer use the remote control. He became just agitated. He became confused. He was aggressive at times. And it was difficult for Mum because she would repeatedly have the same conversation and he'd repeatedly ask the same questions to her throughout the day. And that was all right as us going to visit for maybe an hour and 2 hours, but for Mum it was exhausting listening to this all day. And the picture there looks like she was angry, but she wasn't actually angry. She was tired, and she was tired with trying to deal with everything on a daily basis. And we'd get to a point where we'd say, Mum, we need an emergency family meeting and we need some support at home. And we'd always come to the same conclusion that she felt it was her responsibility to care for Dad. But we did get to a point where we did get some carers in to support Dad with washing and dressing. But even that was a challenge because when you start to let people into your house, you're effectively letting strangers into the home environment, and that's difficult to adjust to. And Mum being Mum, if the carers were coming at 7, she'd be up at 6 getting everything ready for them, and even that put a lot of pressure on her. So it was really difficult for us as a family to watch not only what Dad was going through, but what she was going through too. And there came a point where a nursing home life started to become part of our life. So initially, Dad went in for respite care, but Mum then needed some surgery. And after an extended stay in hospital, unfortunately, Dad went off his feet and he needed to stay in the nursing home permanently. And the guilt that you feel when your dad goes into a nursing home is just undescribable. Mum and Dad had been married for 49 years at that point, and they'd spent every working day together. And Not only was it difficult for Dad, but it was heartbreaking for Mum, and it was a lonely life for Mum at that point as well. And quickly after he went in, it was Christmas, and we'd always been together as a family at Christmas, and it was really difficult. We didn't have the setup at home to be able to care for Dad that day. But we did go to the nursing home, and he looks well on that picture, and we had book spares and we had presents. But there came a point in a day when we had to go home and leave him there. And he cried to come with us, and we cried when we left, but take him home with us. It was absolutely heartbreaking, and I think that day will remain in my thoughts forever because it was so difficult. And then the nursing home life is different than home life. So if your dad needs something when he's at home, you can respond very quickly. In a nursing home, it's different because there's a lot of other people to care for. You have to adjust to that. Your dad has to wait for things, and that can be difficult because you just expect and want everything straight away. And I went in one particular day, and Dad was crying in pain, and he'd been on a slow release painkiller, and he hadn't had it that morning, and it was getting on for lunchtime, and the nurse to me didn't seem bothered. She didn't seem to care. She felt that she'd been busy and she hadn't had time, but she just responded to, I suppose, my aggression, and she gave him some morphine, which he wasn't prescribed that day. And that resulted in an investigation. And what I'd say is, whether it was an investigation, a complaint, or something you were not happy with in the nursing home, what the difficulty is then is you go and leave your dad in that nursing home and you're worried that they're going to treat him differently because you've been unhappy. But it wasn't always sad in the nursing home, and you can see from the picture, although he's shown some deterioration, he still managed to have a little glass of cider, and that was one of the pleasures he had during his time in the home. And he loved the music, so he specifically loved Nat King Cole. And throughout his whole journey, no matter what difficulties, even when he couldn't eat or drink or do anything for himself, if you put the music on, he sang. And then came a day when he didn't sing, and he never sang again after that day. And for us, that was the day when I felt like all of the quality, the only thing he had left was the music at that point. And that was really difficult. But the nursing home responded well, and he liked the football. And for Dad, it was Everton and not Liverpool, but they did manage to put the radio on and let him listen to the match. And I wanted to show these photographs just to say, you know, these are all photographs of Dad's time in the nursing home. And it was a really positive experience at time. And I'd say to all the carers out there, make memories, take photographs, get videos, because these are the memories we've got of Dad. And without these photographs, whenever I try to remember my dad, I can only see him at the final stage of dementia. I can't remember these good times unless I look at the photographs. So Dad started to become unwell, and he was diagnosed with heart failure. And that meant that often an ambulance was getting called and he was being taken to hospital. And often he was being taken to hospital because he wouldn't eat or drink, and the doctor would come out and they'd send him to hospital. And on this particular day, he was admitted to the hospital, and I remember that he was in the resuscitation department and surrounded by people in a busy A&E, and the doctor said to us in front of Dad, and although he had cognitive impairment and he couldn't make any decisions himself, he could still hear everything that was said. And in front of him and all of us, they said, if he should deteriorate tonight, how do you feel about him not actively being resuscitated? That was difficult in a busy A&E with surrounded by people. But Dad being Dad, the next day he didn't even remember he'd been sick, and thankfully he didn't remember that discussion. And then because Dad was coming in and out of hospital all of the time, we wanted to put an end of life plan in place for him. The things that we were struggling with was that obviously at the end stage dementia, then the patient's swallow will go, and Dad was having difficulty swallowing and being assessed as needing thickened fluids. But it often meant to us that he was dry and dehydrated because he hated the thickened fluids. He didn't drink them. And sometimes we'd go and tip the cup up and nothing could come out of the cup. And we really didn't want him to have the thickened fluids. So when we visited him, we gave him regular normal fluids, but we understood the nursing home couldn't do that. Dad was on warfarin and Mum used to visit him every day in the nursing home, but she'd get home and then she'd get a call to say he won't take his warfarin, and so she'd have to get in the car and go back and make sure that he took his tablets. And because he was bouncing in and out of hospital every time he didn't eat or drink, they sent him to hospital. We really didn't want that for him anymore. And I have to say, at this point, I was practically willing my dad to die because I hated the deterioration and he was wasting away. So we met with the GP and we did have power of attorney for health and wealth. And if there's anything I could advise carers out there to do, it'd be to get that in place as early in a diagnosis as you can, when your relative can make that decision for themselves. So we spoke to the GP and we said we wanted his medicine stopping, and she said, well, if he doesn't have the warfarin, he's going to have a stroke and die. And we said we'd accept that because he didn't have any quality of life. We didn't want him going to hospital and didn't want him to have the thickened fluids. And the GP said if he stop the the thickened fluids, then he's going to get an aspirate pneumonia and he's going to die of pneumonia. But we decided that that was what we wanted. We wanted Dad to be comfortable in the nursing home, wanted him to be surrounded by his family when he needed us. At this point in time, the only thing that he could do was have this little glass of cider when he wanted to, and he did manage to have that up to 2 days before he died, and he didn't get an aspirate pneumonia. But he did get an ischemic leg as a consequence of not having the warfarin. And although this photograph's horrible, I don't want people to look at the leg on the left. I want them to look at the leg on the right. This was my dad. This is what he was reduced to. He's got foot drop. His ankles and legs were so thin. And he just had no quality at this point. But up until 2 hours before he died, he was still interacting with us and as a family. And because he died in the nursing home, we could all be together. And in that final week, we played the music he loved. We were all together. We talked to him. We were all surrounded. And if he'd have died in hospital, we'd have never have got that opportunity. And I do still treasure that last week we had with him. We were obviously grieving afterwards. I don't propose to read this out, but I just want to read one paragraph, which was from my daughter, which said, "Grandad, I hope that one day I'll find somebody as strong and will love me like you love Nan, no matter what the circumstances." And I just want people to remember that when you've got somebody in front of you who's maybe confused, agitated, aggressive at times, it's somebody's dad, it's somebody's granddad, or it's somebody's mum or nana. Thanks for letting me share my story with you today. I'll pass you back over to Aideen now.
So thank you for that, Lisa. I've heard that a few times and I still find it very emotional. So I'm sure elements of that story may resonate with some of our carers if they're watching. And I think it's important to talk about these stories and these experiences because this is ultimately, this is a common disease that we're seeing increasingly more of. And actually you as carers, as relatives, are in a position to advocate. One that we remember themes that Lisa's talked about. I'm just going to go to the chat, and I know we're kind of just on time here, but let me just finish. I've got one other slide, haven't I? It was just for some signposting really. So there is a carer's passport that's agreed within the region, so all the 12 trusts within the region have agreed with this document, and it's basically a document for carers to put information in, but also some signposting for carers, so that you've got information that you can share with teams when your loved one gets admitted to hospital. There's some pages at the back which are quite helpful for signposting on for further sources of information, and so there's some that are specifically in relation to being a carer, and then there are some more specialist support services. You know, we're talking about Alzheimer's Society, Dementia UK. These are really, really great resources to be able to access, you know, things like the Admiral nurse in the community, because often it can be that you're in the community and almost feel like you're on your own and you're isolated dealing with these crises. And I think some of the surveys that have been done, you know, show that like 1 in 5 families supporting someone with dementia are reaching crisis regularly. So it's just an opportunity to signpost that. And that's the bulk of the talk, but I'm going to go through some of the questions now, and if we run out of time, I will be able to some via email. I think we can do it. I also just want to use this as an opportunity to highlight there's a carers CAF that is for carers of patients living with dementia, and that's on the 17th of November this week, and you can access, I'll give the information to the corporate team if anyone wishes to access that. So we've got a question about support groups that carers can talk to. So yes, that's a definite. So there are lots of support groups. So there's Tide, Together in Dementia Every Day, the Alzheimer's Society. There are lots and lots of care groups. It's just being able to know what's available, and I think that's part of the problem really, is that there's lots of resources, but it's actually being signposted to those resources. So I can put together the information on the signposting. I'm sure we'll be able to share with anybody who wishes for that, and it's got phone numbers and email addresses. And I think that's really important. I would encourage those that are carers to meet other carers and talk about your experiences, just so you know you're not on your own. And I don't think, unless you're coming from a position of caring for someone living with dementia, it's very, very difficult to imagine some of the challenges that you know that you face. So that's the answer to that question. Can early diagnosis, the next question is, can early diagnosis or intervention help with dementia patients? It's always, the earlier the diagnosis the better, but more from a future planning point of view. So some of the topics that came up in Lisa's talk, so things like aspiration pneumonia, making decisions about eating and drinking with accepted risk of aspiration, all of these things are to know in advance allows you to plan for those. And certainly things like the power of attorney, it's very helpful to get almost just focus the mind a little bit, and you know, get things in place so that if somebody gets to a position where they're not able to make decisions for themselves, conversations have been had about what their wishes might be, but also those safeguards have been put in place that allow you to be an advocate for them as a next of kin. I would say that's that question. So how would you best deal with situations in which loved ones with dementia become aggressive and violent? Now this, we did touch upon this during the last talk back in April, and it's firstly just checking whether there's any triggers to that. So we know that patients with cognitive impairment who aren't necessarily able to articulate, if they've got pain, if they're thirsty, it may be a manifestation of that. So it's making sure that anything that's a potential trigger is being supported. And then it can be very difficult, and this is what we see. We often see kind of carers reaching crisis point and patients being admitted to hospital. There isn't, medications are used, but with varying success and with varying evidence for them, and they increase risk of falls and other things as well. And this can be one of the more challenging elements of supporting somebody with dementia. And certainly going back to my personal story about my granddad, that was certainly from granddad, the changes in his personality made it extremely difficult. Just things like personal care, he was rather agitated with if anyone tried to intervene with that. And it can be really quite difficult. And certainly we've got the luxury for patients that are in hospital, for example, that we can retry, or there can be a different carer, a healthcare assistant that can come and try, who may have a better, just a better interaction that allows us to de-escalate things. It's very, very difficult if you're the sole person in the community trying to support somebody. And this is where the things like the Admiral nurse. So I know certainly I've heard some positive things about accessing the Admiral nurse, which allows you to have that point of contact in the community to try and de-escalate if things are happening, to give some advice and support, so you're not on your own. Are there brain foods that can help delay the onset of dementia? So anything that's good for the heart is good for the brain. So it's all of those things about healthy eating and trying to minimise having high cholesterol. There is some good things on the Alzheimer's Society about healthy eating and prevention of. I'll signpost you to that. So somebody's asked whether we can get. Gosh, we've got lots and lots of questions actually. What's the difference between dementia and Alzheimer's? I would reference back to the presentation back in April, which you should be able to access, because we use and dementia is the umbrella term, and underneath that we have all of our different subsets. So Alzheimer's is a type of dementia. Somebody thought about having some technologies in the form of a dementia clock, and it helped keep him orientated. Yeah, that's what we find. There is actually, the Alzheimer's Society have got quite a few little gadgets and things that just to signpost you that I don't know of any, I've not got any personal experience of gadgets. I don't know whether Lisa's shaking her head next to me, she hasn't personally, but there is things, if you access through the Alzheimer's Society, Dementia UK as well is a really good website with lots of helpful information. I think it's increasingly we use assistive technologies, so certainly there are things like door sensors and bed sensors and things like that, where if you've got somebody in their own home and you're concerned if they went outside on their own, the sensors can be put on the door which would alert anyone trying to leave, and then can keep people safe. So there are some assistive technologies, and there are some things I've seen on the Alzheimer's Society website. So somebody's asked, how do you get a diagnosis? So again, this is really quite tricky, because increasingly community services are stretched. It would be accessed through the GP and a referral to memory service to get the formal diagnosis. Certainly in hospital, we often get the psychiatrist to come and see patients if there's, if we're dealing with an underlying cognitive impairment that's been quite clearly for years. But I would encourage you to seek a referral through the GP to memory services. They are seeing patients, things are up and running, and it would be through the GP really. And I think you'd struggle to get the Admiral nurse involved unless the diagnosis. It would have to be, the GP can give a diagnosis, and you don't have to be seen in memory service to get a diagnosis. We seem to have fallen into a bit of a trap where patients need to be seen by the memory service to access those services. Certainly in the case of my granddad, he was diagnosed via the GP with his diagnosis of dementia because he refused to go to any memory clinic appointments. He was never going to go, but clearly he was cognitively deteriorating, and a conversation with the GP, it was quite clear, loads of wandering and getting lost in familiar places, and real kind of key things that would make you think someone's definitely got a progressive cognitive issue. So I would encourage you to access through your GP, and I know again that's a bone of contention for some people struggling to access GP appointments. That would be the route. And I think we've overrun a little bit now. So I think that's the end of the session. I think there'll be a link sent out where you'll be able to re-watch this. Any questions that you've got that that come after the after this is finished, then please do contact the corporate governance team, and I'm sure they'll forward on, and I will ensure that we've got copies of that signposting sent to the mailing list. You've got access to of them. Thank you very much for listening.